Hi again, it's Lena talking about knee surgery. You're viewing this video because you've been instructed that you might be a candidate for knee surgery. Obviously, we've exhausted all conservative modalities, or I've told you that this was a demand lesion that required something done, or you can get worse in the long run. So I'm going to discuss briefly the anatomy, and then we'll go over different pathologic processes. So this is a model of the knee. The femur is up top, the tibia is down below, the patella in the front. The quadriceps tendon comes down to the patella, patellar tendon down to the tibia. The lateral side has the lateral collateral ligament. The medial collateral ligament is on the medial side. As I open the knee up, we can then see the meniscus, the lateral meniscus, and the medial meniscus, and the anterior and posterior cruciate ligaments, which are important stabilizers. The anterior cruciate ligament prevents the tibia from sliding forward underneath the femur. That is one of the most common injuries that we see in young athletes. It is more common in women than men per athlete hour, and there's really an epidemic of knee injuries in ACLs. And that's why we're trying to prevent them, and there are many injury prevention programs that can hopefully help stabilize the knee and prevent the injury from occurring. So oftentimes, if we're fixing your ACL, we're also signing you up for an injury prevention program for the opposite side to prevent that from happening. So multiple things can happen. We've already started discussing the ACL. The ACL usually is a non-contact twisting injury. You'll feel a pop in the knee, swelling in the knee, and you'll feel that it's somewhat unstable. And if that's the case, we need to examine you to see what is injured. Oftentimes an ACL injury goes with a medial meniscus tear and also with a medial collateral ligament tear. Oftentimes the medial collateral ligament will heal, but usually the meniscus and the ACL has to be addressed. There are many different grafts that we can use, and it depends on what your outcome in life or what your outlook on life is if you want to get it reconstructed. Are you an active individual? Are you a computer person? Do you want to have a stable knee? We will discuss all these options prior to any consideration for an ACL reconstruction. There are many grafts that you can use. There's the quad tendon graft, the bone patellar tendon bone, where you take a piece of the patella, piece of the tibial tubercle to reconstruct the ligament. You can use the hamstring tendons that come around the corner here. We can use them to reconstruct the ligament, or we can use allograft, which is cadaveric tissue. We will discuss with you in the office why we are recommending a graft selection for you, and you can choose to pick which one you want. So that's as far as the ACL is concerned. As far as the ACL post-op protocols, you're protected weight bearing for about 3 weeks. You then start the rehabilitation process. You're running inline in 3 months. You're going to be doing a ballistics program at 6 months, and with a theoretical return to sport activities at the range of 9 months. So other ligaments can tear as well. The medial collateral ligament, if it's completely torn, we have to do a reconstruction of that, where we basically put a graft in the femoral side, the tibial side, and stabilize in the position. The PCL, similar to the ACL, might need to be stabilized. Same type of thing. We drill holes through the bone on both sides and reattach it in the position, and the lateral collateral as well. Other issues that would need to be addressed could include patellofemoral problems. The majority of patellofemoral problems occur because of a lateral tracking patella, so it rides out to the side, which sometimes puts you at risk for a dislocation of the kneecap. And that sometimes can have to do with the Q angle, which is the angle where the quadriceps come down to the patella and then turns out to the tibial tubercle. If that angle is too great, or your TTTG distance is too great, that can lead to the dislocation. So if that is the case, we occasionally have to do a reconstruction of the ligament that tears as it dislocates, the medial patellofemoral ligament, which attaches from the femur to the top part of the patella, stabilizing it in position and preventing it from going off. But if your angle and your tibia is in the wrong place, we occasionally have to do an AMZ, anterior medialization of the tibial tubercle, to get it better in line so that the MPFL will not tear. So I know that's a lot to say, but you can look it up online as well, and we can discuss it further in the office. Looking inside the knee, one of the most common injuries is going to be meniscus tears. If you think about how the femur rides on the tibia, with twisting, you occasionally pinch the meniscus, and that can cause tears in the meniscus. Not all meniscal tears need surgery. It really depends on how your symptoms are. If we're able to get them under control with injections, more power to you. But if you can't get the knee out all the way out straight, if you can't bend it up past 90 degrees, if you're resisting doing the activities that you need to do to be healthy, then we need to consider doing a knee arthroscopy and either a debridement or repair of the meniscus. So other issues associated with knee include arthritis. And so while I don't do total knee replacements, I do partial knee replacements. So this is the Makoplasty partial knee replacement. And so what happens is if you get arthritis, significant arthritis on one side, it causes a varus deformity or a valgus deformity of the knee. As the cartilage wears away, the bones come closer and closer together, so your knee shifts over. So the weight-bearing center that is normally in the center of the knee shifts to the affected side, which increases the load on that compartment. Because of that, it wears faster and faster. So if there's preservation of the lateral and patellofemoral with isolated medial arthritis, we could do a Mako robotic-assisted partial knee replacement. The reason the Mako is important is because it is basically robotic-assisted. We do a 3D CT scan of your knee, put it up into the computer. We then put radio arrays in the femur and the tibia that have the arrays that shine up to the computer, that's sensed by the computer. We put checkpoints in the femur and the tibia, and then we have a probe that has a radio array, and we probe all over the knee, 150 points, to verify the position of the knee. We then bring it through a stressed range of motion, and it allows us to recreate the normal anatomy because we're using the soft tissue envelope of the medial collateral ligament to tell us where to put the implant. And it will also calculate the pressure sensed by the implant throughout the range of motion. So we can now put it in the correct location so that you'll get less pain, less limitation of motion, and a longer longevity of the implant. One final thing is, prior to any replacement, there are other procedures that can be done for cartilage disorders. The early cartilage issues, when you have some fraying, we can do a chondroplasty where we just remove that fraying. Sometimes that fraying goes deeper down to the underlying bone, and you have either an OCD or you have a flap tear. We then sometimes will just debride out that flap and do a microfracture technique where we drill into the underlying bone, which creates a fibrous film that can grow out. Primitive mesenchymal cells come out and grow a layer of fibrocartilage over that to decrease the swelling of your knee and decrease your pain. If that fails, we sometimes have to go to more advanced procedures like MACI, Carticel, and these are cartilage growth procedures where we can implant either fetal or amniotic cartilage cells into this location. And so that would help to resurface the area. If that doesn't work, we sometimes go to Oates procedures where we take plugs from one area, including bone and the cartilage, and we implant it into the more weight-bearing area to act as a weight-bearing surface. And if the defect is too big and we can't get too many plugs, we sometimes will be using an osteochondral allograft, which we need to size and get an appropriate donor to resurface that to prevent you from getting a total or partial knee replacement at that stage. So that is a quick view of all surgeries around the knee. Look forward to seeing you in the office and talking to you more about it.